What happens to the vulva during menopause? Like there are actual physiologic changes.
Right. The tissue between the pubic bone all the way to the sacrum in the female. So we've got the vulva, the labia majora, the labia minora, the vagina, the urethra, and then the perineum, which is kind of the area between the anus and the rectum. I mean, sorry, the anus and the vagina. Yeah. And then, and kind of everything out to the side of that. All of that tissue is very highly estrogenized and has testosterone receptors as well. And when we go through menopause, we have loss of those sex hormones dramatically. We go down to less than 1% of our estradiol levels, and we drop to 50% or less of our previously healthy testosterone levels. So what, physiologically what's happening, the tissue in all that area becomes thinner. We lose a lot of collagen. We lose elastin, so the elasticity of the tissues changes. We lose mucus production. So if you did a biopsy of a premenopausal woman, of her vulva, vagina, labia, you'll have this multiple layers of thick, gorgeous, velvety looking tissue under the microscope with all these goblet cells and lots of mucus production. It's just absolutely beautiful. And then you biopsy her several years postmenopause, and that tissue is just thin. It's down to about 10% of its former thickness, and there's no mucus production. So that tissue becomes easily irritated, friable. The vagina becomes contracted. Sex can be extremely painful. You can actually tear the skin from sex if it gets, towards the end stages of GSM. The other things that start happening are the health of the urethra, the ability to resist the normal bacteria that are just living on our skin at all times. You're much more prone to have an opportunistic infection through the urethra, and we see recurrent UTIs and then urosepsis and all the problems ensuing from that.
Yeah, it's pretty dramatic. I mean, I think what people don't realize is like how much it changed. First of all, people don't ever look. So I always tell my patients, one, I show them their vulva when I do an exam, but I think people should look at their vulva and know what it looks like. And it will actually change. Like those labia will shrink. The tissues will become thinner. I mean, these things are pretty remarkable. Like imagine your penis just shriveled up. Like you would see it. You would notice and you'd be horrified.
And it become painful every time you try to have sex. And then you usually will have some difficulty with erection with age, but not being able to get erect at all, like all of that. And your sex hormone levels, which also help to control your mood and how you see the world and your muscle mass and your bone density. It's as if your testicles shriveled up and died at the age of 51 and all the downfall that would happen. I mean, and that's what's happening to her.
It's amazing. I think that hormones have so many receptors all over our bodies.
Over the body.
They have so many use cases. And I wonder why people have such resistance. I know the WHI did some damage and I want to talk about that, but why do you think people are so resistant, even if they are eligible to take hormones to benefit
the misinformation campaign around, the demonization of estrogen as somehow being bad when it is the most safe, natural thing in our body that we have. It keeps us healthy. And when we lose it, not only do all the things we talked about happen, but your cholesterol goes up, your blood pressure goes up, your risk of cardiovascular disease start accelerating, your A1C climbs. Like if your partners out there all of a sudden with no changes in diet and exercise have elevated A1C, elevated blood glucose levels, a high HOMA-IR score, their cholesterol's up and their doc's like, take a statin, here's your blood pressure meds. When no one talked, we're not teaching the clinicians to connect the dots, that all these things are related. So I think we've undersold the benefits of estrogen dramatically and only assigned it to this kind of selfish, like get your sexy back or something. And we're not talking about the cardiovascular benefits, that you're going to live longer, that you're going to have a lower increased risk of heart attack, and that the younger you are when you go through menopause, the higher your risk is for chronic disease. That's all related to estrogen.
Yeah. And you'll have a less risk of dying of all-cause
mortality. Yeah. Any cause of death.
Yeah.
So we are underselling the protective benefits. Even the U.S. Preventative Task Force, where we know estrogen will decrease your risk of a fracture, from osteoporosis by 50%, will not recommend it for primary prevention of any disease. And it is just ridiculous because we have this, and I think it's how we treat women. I think how women have been treated through history in medicine of stay in your place, just get through it. And we are like rewarded for suffering and suffering quietly. And I don't think the people who are loud about this now are going to back down. And so the medical establishment has got to wake up and realize they're not serving females past reproduction.
Yeah, it's amazing the difference, right? So when you have a woman that goes to a clinic asking for hormones, she's very often told, oh, you don't need that yet, or you don't need that, or you're fine, or it's too late for you.
Or too early.
Or too early, or too late, or you really don't need it.
Your symptoms aren't severe enough.
Right. Whereas a man, if he comes in, at the very least, he'll get a test. At the very least, if he says, I want to get a test for low testosterone, he'll get a test. And then if he wants testosterone, a lot of people will, if he meets the criteria and has symptoms, people will be like, okay. And it's not there's still definitely stigmas in men as well, but I think it's definitely easier for men to obtain testosterone than it is for women to accept and obtain hormonal therapy.
Yeah. And part of the other problem is these antiquated black box warnings that are on even vaginal estrogen. They finally get their prescription. They're so excited. They get home, they open up the paperwork, and it's like giant bold letters, this will kill you.
Yeah.
You will get cancer. You will have a stroke. You will have a blood clot. And it's like,
not possible.
And then they freak out and call me. There is zero evidence, not one smidgen of data to suggest that local estrogen, vaginal, topical, in the dose for topical application, like for the face or for the vagina, vulva, has ever been systemically absorbed enough to do any of the things that they quote.
Yeah.
So these are part of the problems. Like, you open up your prescription, your FDA approved prescription, with a giant scary warning that has really no proof that these things will actually happen to you.
Absolutely. And they won't change it.
They
will eventually, but it's been a while.
We're going to have to sue the FDA, but it'll happen.
Let's talk about the Women's Health Initiative and what were the flaws with that. Well, first of all, what that study was, what the flaws were.
So the Women's Health Initiative was really exciting at the time. So it started, like, first time I heard about it was, I think, med school. I want to say 1995, they started recruiting patients. So the NIH had agreed we need to study women. So we had known for decades that women on hormone therapy. So at the time of the WHI, 40% of women in the US who were eligible were on hormone therapy. So a little less than half. Okay. Mm-hmm. Just to give you perspective, right now we're about 4%. So, and some people say 6 or 7, but like way less than 10%.
That's crazy.
Yeah.
40% to 4%.
Yeah. So, you know what tripled was SSRI use, like antidepressants. Yeah, go figure. So anyway, so we have this study. We know that from observational data that women are living longer and they're having less heart attacks who are on HRT versus those who aren't. Mm-hmm. So the whole purpose of the Women's Health Initiative was to prove that point, because some thought that this is observational data. Maybe it's just because they're healthier and wealthier. Those are the women who tend to go to the doctor and get on HRT. And this is just an artifact because of their socioeconomic status. Not unreasonable. So let's study it, do a randomized controlled, placebo-controlled trial. So they set up the study. They have, I think, 30-something thousand patients between two arms. First arm, you have a hysterectomy. You don't need progesterone. You're getting estrogen only. The estrogen they chose was Premarin. Not unreasonable. That was the number one prescribed estrogen at the time. Okay. The other arm, women still had their uteruses. They got estrogen and progesterone, a progestogen called Provera, very specific synthetic progesterone, which again, number one prescribed in the US at the time. Because they were looking for heart disease as an outcome, the average age of the patient was 63. She was much older. So that's kind of thought flaw. And I don't say it a flaw, but they designed the study to look for heart disease. Doesn't happen till we're older in general. So they had to start with an older population. Okay. Mm-hmm. So these women had not had estrogen in their bodies for 10 to 13 years on average, right? Because average age of menopause is 51. And so time away from estrogen is when the disease starts, right? What percentage of those women already had plaques in her carotid arteries, already had plaques in her pericardial, coronary arteries, sorry. And so what percentage had already had high cholesterol and, all the risk factors for cardiovascular disease? They put them on meds, they start measuring, and a few years in, they noticed that the group who was on estrogen and the progestogen had a slight increased risk of breast cancer. And they called a press conference, I believe, at the Watergate Hotel, had not published the study. No one could see the data, and said estrogen causes breast cancer. We have stopped this arm of the study. Okay, the estrogen only arm still going. They had a 30% decreased risk of breast cancer. Everyone's like, okay, oh my God, because the relative risk is different than the absolute risk. But all was reported, and most lay people don't understand. So relative risk is more of a population risk. So it went from 4 out of 1,000 women per year to 5 out of 1,000 women per year. So the placebo, women get breast cancer because they have breasts. Okay. And so 4 was the baseline. It went up to 5. So they stopped the study. The absolute risk for you and me each year was 0.8%, but that's not what they reported. So the estrogen only arm kept going. They stopped it a few years after that because they noticed a small but not statistically significant rise in strokes. So that was after 7 years of therapy. So they stopped that arm. Those studies have been walked back multiple times. But in 2002, when all that got announced, it was the #1 medical news story of 2002. Mm-hmm. Every magazine cover, every news show, every morning show. There was no internet at the time, but everyone knew this, and 80% of women threw their prescriptions in the trash, and no one would prescribe it after that.
Yeah. You know, it's interesting. Very similar thing happened to testosterone. So when testosterone, they did one study where they saw a risk of heart attack with, and I don't remember the specifics, but they saw a higher risk of heart attack. It got picked up by the media. There was actually an error in the statistical analysis. They took it back. They retracted it. But by that time, the news was everywhere.
And those kind of things stick with the population, like the myth that there's this dramatic association between hormone replacement therapy and breast cancer is resilient as a menopausal chin hair. Like every day on the internet, I'm rebutting that and showing studies and rebutting it. I mean, I'm doing a conference tomorrow here in LA with Avram Blooming, who wrote Estrogen Matters and really helped, all this had been debunked, but no one had put it together, and he put it together in a book and showed really the safety of estrogen and actually the protective benefits of estrogen, besides the ridiculous notion that it has this huge association with breast cancer.
Yeah, it's pretty crazy. So you did mention something. SSRI use went up by 30%.
So one of my colleagues, Heidi Flagg, so she practices OB-GYN in New York City, and she's part of our Menopause, right? So she did this awesome slide looking at the rates of SSRI use versus when HRT plummeted, and then all of the money that went into new SSRIs from big pharma. And I hate to sound like a conspiracy theorist, but it's economic reality. And we saw 4 new SSRIs come out right as HRT prescriptions went down. And then even in 2023, 85% of women will go into their healthcare provider's office, having symptoms, stating the symptoms. It's documented in the chart. Only 10% are being offered any therapy, and 4 to 1, it is an antidepressant.
That's wild.
So we go from 10% female antidepressant use before menopause to 20. So we double. And then 25 after the age of 65.
It's interesting. I don't know if this has been studied in the menopause literature, but in the testosterone literature, it has been looked at that men who take testosterone who are depressed actually have similar responses to SSRI use. Now, that doesn't mean you shouldn't take SSRIs, but the point is that it may be valuable if you have symptoms of low testosterone and a low testosterone, that replacing that testosterone may actually improve your symptoms enough that you won't need an SSRI.
So it's very clear in perimenopause now. And I just, at the Menopausium and Menopause conference in Chicago, 2 weeks ago, there were 2 neuroscientists, 2 psychiatrists, and talking about what's happening on a pathophysiologic basis to women's brains during perimenopause because of the chaos. What used to look like an EKG each month, this ebb and flow of hormones, is now super high rises in estrogen with big plummets, and then progesterone never quite gets to where it used to be, and the whole timing of the amplitude of the peaks is off, and that just continues until you flatline, right? But that perimenopause is very, very vulnerable time for the female brain, and she is more likely to respond to estrogen replacement to stabilize those levels through the transition than an SSRI, especially in perimenopause. And if she's postmenopausal, using HRT adjunctively with her SSRI has a much, she's doing way better.
Let's go to those peaks and valleys. So I've seen patients come in with their whole month mapped out, they've gotten blood draws. I mean, it's wild. And should people be getting that?
I don't think so. It's not predictable, and it's very expensive. I mean, I would love, I have insulin resistance, and I've had it my whole life. And so I wear CGM. What I would love, I think the most accurate thing would to have some kind of a continuous hormone monitor, something that would kind of track us through the month. I think there's some application potentially with the sleep rings that we're wearing for body temperature, because our basal body temperature is very much tied to ovulation, and we can see, at least for women who were not PCOS patients, but people who had normal cycles, regular cycles that were very predictable. And now you can use the body temperature changes to start seeing the unpredictability. There's probably some value in AMH, but we're not there yet. Like checking estrogen and progesterone and FSH and LH is not helpful. It is not predictable. 5 elevated FSHs above 25, you're probably in late perimenopause, but who's coming in for 5 FSH draws, But when I can't tell you how many times women are getting this blood work and they're like, I'm estrogen dominant. My estrogen was over 400 or 300. I'm like, that's perimenopause. You have these massive surges in estrogen. Did they check it 2 days later? Because I promise you it was on its way down. No one sustains that. So I think there's just so much, because we're not training our clinicians, and it's the Wild West in perimenopause and they're making stuff up. I think they're trying, but there's, I don't think it's worth it to have these very frequent hormone tests done to make the diagnosis of perimenopause. All you have to do is listen to a woman and believe her. Yeah. Maybe rule out hypothyroidism or autoimmune disease, or, look at her symptoms, rule out the other things, which is what I do in clinic. And then I say, okay, yeah, I believe you. Let's talk about treatment.
That's so powerful. I believe you.
Yeah.
Right.
I believe you.